Okay, so I think everybody's on. Pam, you there? She might be muted. Okay, so I'm going to mute everyone. If anybody has any questions, then just unmute yourself and you can ask. It'd be easier if you just asked a question than it would be for you to chat, use the chat feature. So just unmute yourself and ask a question if you have anything. So the first thing, like I said, that I just want to make sure, yep, we're working. Okay, the first thing I wanted to talk about, like I said, is this pediatric inflammatory disease that's going on. So it's called novel pediatric inflammatory disease related to COVID-19. It's also closely related to something called toxic shock syndrome in kids, and also closely related to something called Kawasaki disease in kids. So you know, the best information that's out there is on this Kawasaki disease, which is, I'm not sure if it's the exact same thing because they're not saying yet, but presents with a lot of similar symptoms. So we know that one of the things that's happening in COVID is that there's massive inflammation going on in the body. There's people who have stroke-like symptoms. There's people who have cardiac symptoms because of dilation of coronary arteries. And, you know, there's a lot of things that are going on. So about 2 weeks ago, it started showing up in kids. Interestingly, one of the earlier symptoms was that kids were getting conjunctivitis in their eyes, and it was non-infectious. So the blood vessels in their eyes were dilating, and it was not, you know, the typical infectious conjunctivitis. Also, there were kids whose toes were looking like they had frostbite on them, and the skin was actually sloughing off, and they were very itchy, and the skin was falling off and everything. And they were, you know, obviously taking them to the pediatrician, taking them to the podiatrist and stuff. And some people were saying it was a fungal infection and prescribing antifungal medications. But the long and short is what eventually was determined again is this inflammatory process in the blood vessels was not getting enough blood flow to the toes, and that's why the skin was, you know, starting to fall off and stuff. So it's slowly making its way out there. I just looked now on the internet, there's 100 cases in New York, and I don't know if that's New York City or all of New York State, with 3 to 5 deaths as of right before we started. So it's definitely, you know, cropping up. Before that, they were saying obviously that there wasn't much of an incidence in this in kids, you know, but now it seems for some reason to be affecting, you know, small children. Now, the issue we have is there's not a thing that we're going to be able to do for these kids pre-hospitally. In fact, the diagnosis is, you know, really made with blood work. So it's not something like that we could even figure out in the field, except that there's some classic signs and symptoms. The big question would be taking them to the appropriate facility. So, you know, obviously the hospitals are starving for patients. So if you call up and say, should I bring this to, you know, Good Samaritan, they're going to say yes. But if you have a high suspicion of it being this type of disorder that we're going to talk about now, they probably belong in a Westchester or a Hackensack or something like that versus a community hospital. Because if you bring them to the community hospital, as soon as they, you know, decide that this is something they can't handle, they're just going to ship them out, which is, you know, basically going to delay their care probably anywhere from, you know, 4 to 6 hours. You know, for them figuring it out, arranging transport, getting an accepting doctor at the other hospital and stuff like that. So again, we have not seen it in Rockland, but, you know, it's, I guess if it's in New York, it's only a matter of time before we will. So the blood vessels become very inflamed, and we know that if a substance or a structure becomes inflamed, it tends to not allow, right, it swells, so it tends to not allow blood through it. Now in Kawasaki, which is may not be this what we're talking about, but similar symptoms, it mainly tends to affect the coronary arteries in the heart, okay? And the arteries get inflamed, there's a risk of aneurysms, and whenever you have a risk of aneurysms, there's a risk of blood clots. And obviously throwing a blood clot in your coronary artery would be a heart attack, right? It would be the equivalent of a heart attack. So this is what's happening in kids, okay? They don't know why it happens. So there's about 7,000 cases per year in the United States, and 400 of those cases result in disability in the child where they have, you know, long-term disability, usually related to their heart and stuff like that. Okay, and this presentation was from Seattle Children's Hospital. So they said 7% of their patients develop coronary artery aneurysms despite being put on anti-inflammatory medications. Okay, so in Japan, where it originally started, okay, there's a much higher incidence, about 250 to 300 per 100,000 kids. So in the United States, it's about 20 per 100,000 kids. Okay. Now, what was interesting in Seattle Hospital, 70% of the Kawasaki disease patients, pediatric patients that came in, were not of Asian descent, and it was originally considered to be a disease that mainly affected kids of Asian descent. This one that we're facing now with the COVID obviously is indiscriminate. It doesn't matter, Asian, not Asian, or anything like that. Now, the diagnosis criteria is a fever for greater than 5 days. Okay. Now, they don't put down exactly what the temperature, but typically if we're talking fever, it's over 100.4. In this Kawasaki, it tends to be higher, but usually if we're talking about fever, it has to be 100.4. Okay. And they have at least 4 of the 5. Okay. A non-purulent conjunctivitis, which means it's not the weeping, oozy, infectious one that you're familiar with. Okay. That the lymph nodes in their neck start to swell. Okay. They get a red, itchy rash. Okay. On their tongue, I'll show you in a second, they get this very distinctive pimply type of rash on their tongue. Okay. And then again, like I was telling you before with the toes, and it could be the fingers, they have basically the skin starting to swell and slough off from lack of blood flow to it. Okay. They don't have to all be there at the same time. They don't have to all be there at all. Okay. And there are other, things that are included, especially with these ones now with COVID. There's some of these kids have a respiratory, some of these kids have GI problems, which are not typical of the Kawasaki. Okay. In the Kawasaki disease, the rate is higher in children younger than 5 years of age. And right now, most of the cases in New York are under, I think they said under 14 years of age. Okay. It is possible to have it in older children. Okay. And in older children, it's usually misdiagnosed because it's not that common in older children. So the first thing, again, I don't know how well, can you make out the slides that are up on the screen? Can you guys see the slides are up on the screen? Hold on. Yes.
Donahue on Sandra Drive.
Okay. Okay.
Yeah, I see it.
Okay. Just pull.
Okay. So they get this conjunctivitis around their eyes. Okay. The reddened skin. Okay. You're going to see in a second the lips, but also hold on. Okay. That's the conjunctivitis. So they get this very distinctive, rash on their tongue. And the lips, again, because of lack of blood flow, look like almost like they bit down on them and have, wounds on them and stuff. Okay. Again, the rash. Okay. The fingers and toes getting swollen, and you can make out a little bit of the skin starting to slough off in certain places. Okay. Neck swelling. Okay, all in there. Okay, so a Kawasaki, they're not exactly sure the cause of it, but usually it exists in the presence of a viral infection, which obviously is what we have right now. Okay. And they don't know what's causing, they do know that obviously COVID-19 is a massive inflammatory stressor on the body. And in fact, most of the breathing problems are actually inflammatory in nature. They were, having a lot of different speculations and stuff, but that's why now they're finding that putting patients on vents are really not helping them. Putting really what's getting the inflammation down by using various different inflammatory medicines seems to be much more useful. They're allowing COVID patients now with pulse oxes in the 80s to be, not on any type of ventilatory support, whether it be CPAP, BiPAP, or a ventilator, that they actually tolerate for some reason these very, very low pulse oximetry levels, and they don't need the ventilatory support, because most of these patients, as we've heard, that went on some type of ventilatory support wound up actually, still dying. So they've gone the other way now, which giving them medications that suppress the inflammatory process. Okay, so again, a fever, 7-day history of fever, or at least a 7-day history with 2 or 3 of the other criteria. And infants less than 6 months of age, 7 days of fever with some type of lab evidence of inflammation, and no other explanation of why. In other words, lab work is not indicating any other infection or anything like that in the body. Okay, some of these patients go into a situation where they drop their blood pressure and go into shock, and it's very, very difficult to keep their blood pressure up. And those are the ones that usually do not do well. It's again usually related to some type of cardiac muscle damage, so it's a cardiogenic shock type of issue. Talking about ECMO, which stands for extracorporeal membrane perfusion, which is they basically cannulate the femoral artery and vein and pump the blood through a machine that cleans it and oxygenates it and pumps it back into their body with these kids. If they survive that shocky situation, they may wind up being on an LVAD, machine to allow to take the load off their heart, a left ventricular assist device to take the load off their heart while their heart tries to repair itself. Okay. I have to take my glasses off to see this, but this is showing you a coronary artery. This is a cardioangiogram, and this is the aneurysm. This is the dilation. So an easy way to think of an aneurysm is if you saw a car tire that had a bulge or a balloon in it. So that's basically what happens. Now, we're always afraid of the, quote, rupture of it, right? So obviously, if you rupture a coronary artery, you're going to have massive cardiac tamponade. So in other words, that blood is going to spill. The heart is in the pericardial sac. So that heart is going to spill into the pericardial sac and fill it and compress the heart, and the person will die from lack of filling of the heart. That would be rare. But one of the big issues that happens when somebody has an aneurysm, it could be anywhere, it could be abdominal, thoracic, coronary, cerebral, is that when the blood is now flowing through this artery, it's not flowing well, right? Because it is a bigger area, and blood that doesn't flow well tends to clot. So let's say you get a little clot up in here, and now there's fresh blood coming in and it flushes that clot, and it goes down and lodges, and basically now you have a blocked coronary artery, which is a heart attack. So that's one of the risks. So you'll see one of the treatments that they put these kids on is, very heavy aspirin therapy to prevent the clotting, from occurring. So the first thing is they put them on immunoglobulin, kind of a medication to mellow out the immune system. Okay, now obviously anytime you mellow out the immune system, you run the risk of secondary infections, but we have to assume that these kids are, in the hospital, probably in isolation because they're afraid of, them spreading it to someone else. So there's probably not a risk of them catching another type of disease. Okay. So it's very effective. It's given early, and early they define as 10 days within the illness. Okay. And 20% of coronary artery inflammation and dilation, 8% of aneurysms. So when they had it, there was less of an incidence of having problems with the heart. The other very important medication, okay, is aspirin. So we know already that aspirin has a very, very good anti-inflammatory, right? That's why they use it in arthritis and stuff like that, a very good anti-inflammatory response. Okay, and we know from the situation, and when we use it in the heart attack patient, that it prevents platelets, okay, from attaching to themselves and causing clots. So the dosing they're going to give them is higher than we would be giving, in a heart attack type of situation. But again, that's weight specific dosing. So it's not something that you're going to be doing. So you see here, low dose, 3 milligrams per kilogram per day, maximum of 81 milligrams per day. So that's one, chewable baby aspirin. But we're talking, again, these being very, very small kids. And obviously too much aspirin is very dangerous to the liver and stuff like that. Now, ibuprofen, which sometimes parents don't know the difference between aspirin and Tylenol and ibuprofen and stuff like that. Ibuprofen would be horrible because that interferes with aspirin, the antiplatelet action of the aspirin. So that would just present with more clotting. Okay. So now what's the deal with as far as the house, right? The kids coming home out of the hospital and stuff like that, because again, you're going to have children that survive this, come home, and, the parents are going to have a tough time with this. So 5 to 7 days of fever at home. That's before probably they went into the hospital. They're very irritable, many sleepless nights, right, for both the parents and the kids. Okay, they have multiple doctors appointments, specialists, the city or Hackensack or Westchester or something like that. It's a very difficult diagnosis. A lot of times they think it's bacterial in nature, so they put them on antibiotics. And you know that when patients are put on antibiotics, there's a risk for all types of GI problems, right? Whether it just be something mild like abdominal pain and diarrhea, or something, very serious like C. diff. Okay, so that's an issue. Okay, it's very scary to the parents because there's not a lot of information out there. Could you imagine, the parent who finds out their kid has it now, secondary to COVID, and everything they're hearing on, the radio and news and stuff? There's a high potential for long-term cardiac disease in these kids. Okay. The medication sometimes has to be, given at multiple times throughout the day and night, and has to have constant vital signs so the kid's going to be woken up. Okay. And then the other issue, obviously, is the parents. If it was your child, you would expect, very efficient, quick treatment and, rapid cure of the disease, which this is not that type of problem. It's not something that's going to go away very, very quickly. Okay. The nursing to discharge instructions or something, just so you know what the parents basically should be told, okay, that it's going to be a long haul as far as behavior. They're going to be cranky, irritable, not feeling well for up to 4 to 6 weeks, probably even a little longer. They're going to be tired, so sleeping is, again, going to be their way of dealing with that. Okay, like I said, they're constantly irritable. Their hands, feet are uncomfortable from the skin peeling, itchy, okay, painful. And their skin itself is going to be very, very sensitive to sunlight and, you know, rubbing and stuff like that for probably months. Okay. Not that this really pertains to us, but, you know, God forbid you know somebody, they don't want any live immunizations, okay, because they're giving them medications that kind of suppress their immune system. So when you give somebody a live immunization and your immune system is suppressed, there's always a chance that you can actually get the disease that the vaccine is supposed to protect you from, okay? Also, most immunizations would be delayed just because there's a good chance that they may not actually develop the immunity to it, okay? And then they, can get the influenza vaccine. I'm not sure why that one, probably because it's an inactivated one. Okay, so aspirin is one of the most important, okay, medications for them to get. And they're going to take that aspirin at home for probably weeks, if not months, when they're finally discharged from the hospital. And then, you know, the long-term prognosis with kids who had the severe version of the Kawasaki disease, you know, where it actually caused coronary artery aneurysms and, you know, heart damage, is that they're going to have lifelong heart problems. Typically, they're going to have a weakened left ventricle, so they're going to be prone to being tired and weak because they're not pumping out enough blood into their aorta. Also, they're prone to going into failure because if the left ventricle can't pump into the aorta, the blood is going to back up into the left atrium and then back up into the lungs, and they have issues with congestive heart failure. Because of that, they're going to have restricted activity. They're not going to probably be the person running marathons and stuff like that. There's probably going to be a need for, you know, extended cardiac treatments and stuff. They may need to be reshaping of the ventricle and, you know, all various different things. They may need to actually stent open the artery. Long-term need for, you know, anticoagulation. And statistically, and then again, this is Kawasaki disease. This is not what's presenting right now, although they're very similar. They tend to, you know, die not in their 50s and 60s, but in their 40s. Okay. Now, there was with Kawasaki some thought that that soy had some correlation to the risk of it, but that's not been 100% proven, and I don't think they're looking at that in COVID or anything like that. Okay, so that's basically, you know, what we're, I just unmuted everyone, what we're looking at with this. And, you know, this is a novel disease just like COVID was. So we never saw this before, secondary to COVID, because COVID never existed before. So you may get calls where parents are just suspicious of it and call 911 and want the kid to go to the hospital. So I would do a good history, you know, get the information, and then
Why am I
somebody,
getting all this feedback?
yeah, I'm going to mute everybody again. Somebody's speakers, their mic and their speaker are close together. You know, they may just be calling for reassurance, or maybe wanting that child transported to the hospital for blood work, quote unquote, or something like that. So if that's the case and they're not acutely ill, you probably could call medical control at Good Samaritan and say, you know, what do you want us to do? I would assume if it's anybody but the medical directors, they'd probably tell you to go to Westchester because they don't want to deal with it. But, you know, you can, if they're not severe, I guess it would be okay to go to a community hospital just to have them examined. And then if they need to be transferred someplace else, they could be. Okay, so any questions on the Kawasaki, or whatever, what we're going to call it, the inflammatory disease that we're facing, or the kids are facing now with the COVID?
Yeah, Frank, I have a question.
Mhm.
With some of these signs and symptoms, could any of them be vaccine related as well?
No, has nothing to do with vaccines.
It's specifically the Kawasaki with the COVID.
No, it's not the Kawasaki. They don't know that it's Kawasaki. What they're thinking is that it has something to do with COVID.
Okay.
They're
Okay.
thinking it's because COVID is a inflammatory, you know, disease in itself. So they're thinking that this has something to do with COVID. And again, this is very early in it. So, you know, there can be definite changes in this, but yeah, no, this is not anything to do with, you know, vaccines. As far as I know, you know, I know there's the conspiracy theory as far as autism and vaccines and stuff like that. But as far as I know, I don't think there's really been any 100% scientific, you know, tying in of, hold on one second. vaccines to actual disease.
Okay, thank you.
So hold on one second. Do you see the pneumothorax up on the screen now?
Yes.
Okay. Okay. So
Yeah.
if nobody has any questions, then we'll start with the actual trauma and shock and everything like that. Okay. Okay, so we're going to talk a little bit about thoracic trauma. So we know that the thoracic cavity, the chest cavity, has most of your vital organs, right? Has your heart, your lungs, all your great vessels in there, and it's basically a sealed cavity, and you breathe basically on pressure changes, and those pressure changes are caused by muscles moving, your diaphragm and your intercostal muscles contracting, makes your chest, your thoracic cavity bigger, and when it makes the cavity bigger, the pressure inside the cavity has to fall. And it falls less than atmospheric air, the pressure in the air around us, and that causes air to come in. And then when the muscles relax, the chest cavity gets smaller, the pressure inside your chest increases, and that exceeds the pressure in the atmosphere, and you exhale. So that works wonderfully as long as the integrity of the thoracic cavity is kept in place, right? So once you start having holes in the chest or the lung or anything like that, those pressures changes don't occur and people don't breathe well. So that's kind of, what we're dealing with when we have situations where we talk about chest, chest wall injury and stuff like that, and lung injury and stuff. So, the most common serious thoracic injury probably out there is a pneumothorax. And pneumo, we know, means air, and thorax means chest. So you should have air in your lungs. You shouldn't have air in your chest cavity, right? So the air should not be inside the lungs. And remember, your lungs are not bag-like devices. They are, sponge-like devices, right? So they're like have miles and miles and miles of tubes and blood vessels in there where gas exchange takes place. Then obviously the gas exchange doesn't take place in the tubes, but at the end of the tubes are your air sacs or alveoli. And that's where the pulmonary capillaries wrap around, and that's where the gas exchange actually takes place, okay? So how can we, well, first of all, there's many different types of pneumothoraxes, right? So there's your simple pneumothorax, there's your tension pneumothorax, there's your spontaneous pneumothorax, there's your hemopneumothorax. No way in the world are we going to 100% know which one we're faced with, maybe the exception of the spontaneous, because all spontaneous means is, sudden, obviously, but it's a non-traumatic pneumothorax caused by lung tissue disease, where somebody has a weakened lung, okay, and that's very common in COPDers. It's also common in people being ventilated, intubated, and ventilated with bag valve masks, because sometimes if people don't pay attention to squeezing the bag valve mask, they can put too much air and overpressurize. Supposedly, there's some correlation to the tall, thin, people, and they usually say tall, thin male. But what happens in a spontaneous pneumothorax is typically at rest, maybe with laughing, but, typically at rest, they all of a sudden have sharp stabbing chest pain and they blow a hole in their lung. So there's no outside injury that we would see on their chest because this is an actual defect in the lung itself. So now when they take a breath, that air leaves the lung and goes into the chest cavity. So if when they exhale, they suck the air back out that hole, there's no pressure inside the chest, and then it would be a simple pneumothorax. So the lung will still collapse, but you won't get the pressure building up in the thorax that's the killer in a tension pneumothorax. Now, if that hole becomes a one-way valve where when they breathe in, it goes out the hole, goes out into the chest, but when they exhale, they can't suck it back out. Picture what happens. Every successive breath now, they're putting more air and more air into the chest cavity. And at some point, they pressurize the chest cavity and they start to collapse the lung, okay? But that doesn't stop at that. In a tension pneumothorax, what happens is the pressure gets so great that it causes what's called a mediastinal shift. So what happens in a mediastinal shift is that, let's say I have a tension pneumothorax on my left lung, right? So it collapses my lung, it pressurizes the side. And as the pressure continues, it collapses the lung further, right? So in a simple pneumothorax, the lung collapses, but not to the same degree, right? They always say the percentage of the collapse. So in a true tension pneumothorax, you're gonna have 100%, collapse or 95% collapse. And a simple, you could have a 40, 50, 60% collapse, but it's not typical to have a 100% collapse. But in a tension pneumothorax, because the pressure continues, now it's, again, this is where I have my injury, it's gonna start pushing. So you have the heart in the center of the chest with the pericardial sac. So it can't really crush the heart because of the pericardial sac. But what's gonna happen is it's gonna start to push, right? Now, your trachea, right, attaches to your your two bronchi that go to the lungs. So one of the things you could have is what they call a tracheal shift or a tracheal deviation. That's really an X-ray finding, and I'll show you in a second why. It's very hard to see it on the neck, with physical exam. But you're going to start having that. But now what starts to happen is that when it starts to shift everything over, it puts pressure on the two low pressure vessels that bring blood into the right atrium, the superior and inferior vena cava. Because again, they're veins, even though they're big veins, they're veins, and they're veins at the end of circulation. So the pressure in them is not great, right? That blood has traveled through the whole body, and it's about to spill into the right atrium to go to the lungs, right? Right atrium, right ventricle to the lungs. So it's a low pressure vessel. And what happens is the pressure starts to kink off onto those blood vessels, and it doesn't let blood flow continue. So it doesn't let blood get back into the heart. So people who have a tension pneumothorax, even though, you say, oh, they dropped the lung, they collapsed the lung and everything like that, they don't typically die of the hypoxia because the other lung is still usually working, unless they have bilateral pneumos. But what they die of is what's called obstructive shock. And the obstruction is that the superior and inferior vena cava are pressed on or compressed, and there can be, or obstructed, right? That's why I call it obstructive shock. So there's no venous return to the heart. So if you remember a pump, right? A pump has to have fluid coming in one end and to be able to pump it out the other end. So the heart wants to pump out the left ventricle into the aorta, but if it doesn't have any blood coming in the right atrium, it's not going to be able to pump. And that's why the person dies of shock. So that's the killer in a tension pneumothorax. Now, we were talking simple pneumothorax. This is non-traumatic, and it's really a matter of luck in this person. Do they get a simple, where the air goes both ways and there's no pressure? So they still, they still drop their lung. They still have problems breathing. They're still in pain, but they'll get a chest tube and they do fine, okay? Versus the person who has a tension pneumothorax, okay, who can die before they get to the hospital from the shock that occurs. And it's just a matter of luck, again, with somebody who has a simple pneumothorax, which way it goes. I'm sorry, not simple, a spontaneous pneumothorax, whether it becomes a simple pneumothorax or they're unlucky and it becomes a tension pneumothorax. So that's what basically, we're facing with the pneumothorax. So if we have a closed pneumothorax, that means there's no hole on the chest wall. Okay, remember the chest wall could be your back, right? Your thoracic cavity goes from your front to your side to your back. Okay, or it can be an open pneumothorax, and I'll show you sometimes what happens in an open pneumothorax is they develop what's called a sucking chest wound, which is they actually start to breathe through the hole, and I'll show you that in a second. So again, in this situation here, okay, so a normal lung basically fills up your whole thoracic cavity. So obviously all along here are ribs. And if you've ever seen like a rack of spare ribs, if you turned it over, there's that shining layer over it. So that's called a pleura, pleura, P-L-E-A-U-R-A, I think it is. So you have on your lung a pleura, and you have on the inside of your rib cage a pleura, right? So picture there's these two shining linings, and the lung is basically touching right up against the ribs, except for a tiny minuscule amount of fluid that acts as a lubricant, okay? So that when the lung is expanding, it could slide across your ribs and not cause any pain. And the other reason you have this lubricant is, you ever see sometimes you take, I don't know, 2 pieces of glass, or you have a pot on a countertop and there's a little bit of water between it and it sticks? That's called adhesion, right? So when you have 2 smooth pieces of material with a tiny amount of fluid between it, the 2 smooth pieces of material tend to stick together. So what happens with your lungs is that you have, this is your rib cage, this is your lung, right? They're both that shiny pleura, and you have that little bit of fluid between it. So they're sticking. And when you now take a breath, right, and your diaphragm goes down and your intercostals go out and the chest wall starts to go out, it actually pulls on the lung and expands it so that the pressure inside the lung drops. So again, that works perfectly until, if you look over here, what happened? This person looks like they're going to, show us a spontaneous pneumo. This person blew a hole, okay, in their lung, or maybe they had a rib fracture with no external signs, right? No puncture on the outside, but it just punctured the lung. So they made a hole in the lung. And now when the air starts to escape out the lung, it pressurizes and starts to collapse the lung. Okay, so that's the issue. So now that adhesion that's supposed to be taking place can't take place because you have air breaking the seal. So that's one of the things that will happen when somebody has a pneumothorax. Okay, So open pneumothorax are pretty rare, right? Somebody has to be shot, stabbed, puncture wound or something on their chest. I've never seen one from a rib breaking and protruding outward. I'm sure it's happened, but I've never really seen one on that. So the issue that we have when somebody has an open pneumothorax is that if they start to breathe and suck air in through it, they're going to collapse the lung. So we want to put something over this wound that's called an occlusive dressing that allows the patient to exhale. So we typically seal it on 3 sides, okay? So that when they exhale, it presses up on the occlusive dressing and allows the air to leak out. But when they breathe in, it sucks it up against the hole. And since it's occlusive, it's plastic, it doesn't let air through, right? It doesn't let any air in, so they can't breathe through the hole. Now the problem, in theory, this should work perfectly, but the problem is that there's blood involved here. And you know that once blood dries, it starts to get sticky. And what happens is it typically causes the plastic to stick to the wound, so it doesn't really work. So the days of plastic over wounds doesn't really work. So there, there's commercial devices out there that work much better now, that you could, voluntary ambulance could use. There's no reason they can't use them. For the most part, people don't tend to buy those things on the BLS level, but we do have them on an ALS level. But on the test type of thing, the right treatment for an open pneumothorax would be to seal it. Now, some people say seal it on 3 sides and leave one side open. Some people say seal it on 4 sides and just leave a corner open for it to vent. I would probably seal it on 3 sides and leave one whole side open, because if you need to, release the pressure because it's sticking to the blood, it'll be easier to be able to get your hand underneath it to lift it up if you have one side completely free. So let me show you over here for a second what the okay. Can you hear this? Can you hear this?
Frank, we can't hear it because you have your headphones on.
Okay, hold on. Let me see.
Yes?
Yes.
Okay, I'm going to start it over again.
I can't hear it. You? We can't hear you. No.
You can't hear it?
Sounds like the
No?
headphones.
Frank, you have to keep your headphones on. So right now, it's going into your headphones.
Who's on? Can he hear you?
Hold on.
There you go.
No. You still don't hear it, right?
No.
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 Okay. I don't know why.
No, that's him.
can't
Oh,
do
that's
that.
it.
That's
No, that's him.
Hold on. There's a way of making, okay, share computer sound. Here it is. Okay.
Any injury
now?
located between the
I
umbilicus
can
or the
hear
belly
it.
button and the neck should receive an occlusive dressing. When an injury to the chest is identified, it should be immediately covered with a gloved hand. When the medic is ready to conduct a more thorough inspection, the gloved hand should be removed and the wound should be exposed. The medic should then look, listen, and feel for signs and symptoms of an open chest injury. Those signs and symptoms include
So this is a real gunshot wound. You can hear him breathing through it.
Remember that open chest wounds are highly dependent upon position. Tissue shifting can open or close the wound. The chances of shifting tissue concealing the injury is more likely on an overweight casualty.
This must have been an Iraqi prisoner.
After the wound has been assessed, it should be covered with a chest seal.
This is
Here we
fake.
use an Ashman chest seal, but the same treatment can be accomplished with plastic and tape.
So this is an
It is
old
highly
style
recommended that you put tabs
one
to ease the opening of the
that we
package.
used to carry. There's
Once
a better
the
one
package
out
is
there.
opened, your first step should be to remove the gauze from the seal. Use the gauze to dry the area around the wound site to ensure the seal adheres to the patient's skin. Next, remove the paper backing from the adhesive. The seal should be placed so the valve is located directly over the wound site. In times of limited visibility, you may need to use your fingers as guides for the valve. Place one finger on the wound and one finger on the valve. Lower the seal to the wound until your fingers meet. Remove your fingers and apply the seal. As with any treatment, it should be immediately assessed.
So what's supposed to, well, first of all, when he's talking about limited visibility, he's talking that they're in a combat situation where they can't lift their head up because, people are shooting at them. So they're doing it, all by feel. So the way this device should work is that you see this little finger-like projection. So when the patient exhales, the air should come up through here and vent out. And then when it inhales, it should flop it over and collapse it and not let the air in. So the problem with this was that if you put a blanket over the patient, it interfered with that. So that's why we kind of got away with that. So I could show you a couple other ones that are out there, but it's the basic same technique, except they got rid of that, Penrose drain that was kind of sticking up out of it the way it was here. Now, in trauma, all of this should be done en route to the hospital, right? You're not going to stay on the scene. Everything you do in trauma is en route to the hospital. If the paramedics aren't there, you don't wait. You start transporting. Again, IVs do not save trauma patients' lives. Surgery saves trauma patients' lives. So anything you could do to get them off the scene and start going to the hospital as quick as possible would be the most efficient treatment to them. And the protocol even says that you can bypass a community hospital to go to a trauma center, upwards of 30 minutes away if that's the closest trauma center to you. And remember, we have a level 3 trauma center in our county, and we're going to have a second one. Good Sam is also going for it. They have provisional approval, but they didn't go through the survey from the American College of Surgeons yet. But, level 3s are the lowest level trauma center. And if you have major multi-system trauma, you'd be better off taking the ride across the bridge. If you have pediatric trauma, you have to take the ride across the bridge. If you have burns, you have to take the ride across the bridge to a level 1 trauma center.
After treatment is completed, the casualty should be monitored for signs and symptoms of a building tension pneumothorax.
And we'll talk about all these things in a second. Okay.
Any injury located between the umbilicus or the belly button and the neck should receive an occlusive dressing.
Okay. So we talked about this concept already. That's the Ashman chest seal on the left there, and that's also the Ashman on the right with just an exaggerated amount of tape around it. Okay. This is one of the newer ones they were using. So the advantage of this one, it's a little hard to see it, but this device sits right here, right? So the same thing, you center it over the hole as best you can. And the venting takes place over here underneath it. So if the blanket was laying on it, it would not be obstructing the venting taking over. And then there's a new one, the hyphen one that's out there. It's a similar type of venting system where you don't have to worry about blankets interfering with it or anything like that. But remember, one of the biggest killers of trauma patients is hypothermia, is low temperature. When somebody is cold and they're bleeding, they tend to coagulate worse. So if you don't coagulate well when you're bleeding, you bleed more. So they talk about the Triad of Death, like the three things that pertain to a trauma patient dying. So one is cold, hypothermia, the other one is hypoxia, and the other one is acidosis. So, and bleeding is the cause of all of that, but the three actual things that kill trauma patients are acidosis, that's caused by the shock, the hypoxia, okay, and the hypothermia. So in the field, it'd be very, very important to, wrap the patient up as quick as possible. Now, the county, when they were distributing some of the COVID equipment the other day, I don't know if you guys got any, but they actually distributed what they call Casualty evacuation bags. So they're shrink wrapped into a little green container, but these are the actual bags that the military is using on trauma patients to evacuate them from the scene. And there's actually a heat source in there that kind of works like a hot pack. So you would put the patient inside the bag, and then there's pockets that these heat sources go into, and the bag itself retains the warmth. It's not aluminum, but it's a plastic that actually retains the warmth. So that if they were medevacing a casualty, say from a frontline situation, they would put them in that bag before they put them in the medevac to fly them back, and it would, give them some external heat, inside the bag and prevent them from losing any more heat. So the county distributed, we got 5 of them. I don't know if they just gave them to ALS agencies. It has nothing to do with COVID. I guess they had them laying around and stuff, but it was interesting because they're about $150 a piece. So they're pretty expensive, devices. But if you had a, trauma patient that was going to have a long transport in less than ideal temperatures, that would be the device you would want to use. Okay, so just a couple pictures. This one obviously is a staged picture because the guy's smiling, but they were showing you back in the 50s, right, or even before that, the treatment for a chest wound was to put dressing over it. Right? The problem back then is they probably didn't use occlusive dressings. Okay? Recently,
10,000 patients.
I'll mute everyone. Okay, and then nowadays. Now again, when there's a lot of blood, very difficult. That's why the first thing they showed you when they were putting on the dressing was to take that gauze and dry it off. Now that gauze pad would obviously be a waste of time. You just want to get a big multi-trauma dressing and dry them off completely as best you can. Penetrating chest wall injury, there's no use in the world for putting hemostatic gauze on it because you can't press the hemostatic gauze on the bleeding vessel, right? There's just no way to find out what's bleeding inside of somebody's chest. Hemostatic gauze works best when it's an extremity injury and it's a laceration. And then what you would do is you would wipe the blood, right? Take not your hemostatic gauze, but anything, a towel or another regular gauze pad, and wipe the blood out of the laceration if it's pooled in there. And where you see the bleeding coming from, then you're going to pack your hemostatic gauze down onto it. And then you could pack regular gauze on top of that. And you want to fill the wound up, but you want the hemostatic gauze to be pressed up against the bleeding vessel. Pack it with something on top of it, and then you hold direct pressure on it. And it typically takes about 2 minutes to control the bleeding. If for some reason the hemostatic gauze is not controlling the bleeding, the appropriate thing would be to go to a tourniquet, right? Sometimes people say, oh, I'm going to put more, or I'm going to press harder, or I'm going to give it a little longer. If you have severe bleeding, whether it's arterial or venous, and you have not controlled it in 2 minutes with hemostatic gauze, then you need to go to a tourniquet. Now remember, tourniquets are always applied what they say proximal to the wound. So that means if my wound is here, the tourniquet has to go between the wound and the heart. That's proximal. So distal would be the wrong answer. You always want to be proximal to the wound, and usually it would be not over the wound, but just slightly proximal to it. The other thing is if I have a laceration here, it'd be better to put it below the elbow between the wound, if you could, than it would be to put it above the elbow, because if that patient survives their injury, they didn't die from shock or something like that, and let's say the tourniquet wasn't taken off quick enough and they have to have an amputation, it'd be better for them to have their own joint and have the prosthetic device here than it would be to have to get a prosthetic device here with an artificial elbow. Now, don't fear that putting a tourniquet on someone is going to result in an amputation, because the military has studied tourniquets extensively, and tourniquets that are put on and removed within 3 hours do not usually result in an amputation unless there was going to be, because of the trauma, the reason you put the tourniquet on, there was an explosion or a bullet and it destroyed the extremity. But the tourniquet itself is not usually the cause of an amputation if it's removed within 3 hours. And obviously, tourniquets have to be tight. You know the tourniquet is successful when the blood flow ceases. And the protocol update that we went to, they talked about putting tourniquets, but they talk about high and tight, which would be up here and in the groin. That's a military thing. So if you're in a situation where you're being shot at while you're rendering care and you can't lift your head, then you go high and tight so that you don't have to examine the extremity to find out where the bleeding is. You just shut off all blood flow to the extremity. In a civilian setting, where 90% of the time, it's a saw accident, a chainsaw accident, or something like that, or a car accident, there's no danger to us. It'd be better to put it just proximal to the wound, so that if there winds up being an amputation, you can salvage as much of the joint as possible. Okay. So again, if hemostatic gauze fails to control bleeding within 2 minutes, and trust me, 2 minutes is a hell of a long time when you have severe bleeding. Nobody even waits 2 minutes. But if hemostatic gauze fails to control the bleeding, you go right to a tourniquet. Now, one of the other things they put out in the protocol update is can you loosen a tourniquet? So, for decades, as long as I've been doing this, right, it was you never loosen a tourniquet. If you loosen a tourniquet, there's poisons that are released and acids that are released, and it's all nonsense. It's not true, okay? So the rule basically is that if you have controlled bleeding, right, and the bleeding has stopped and it's stopped for, 5 minutes or say 10 minutes, okay, you can start backing the pressure off the tourniquet. In Rockland County, there's never going to be a need to do that, right? You're going to be at the hospital before that happens, unless somebody's entrapped or something like that. And in that case, you're probably not going to be loosening anything because they're entrapped and you don't know what's going on. But, if you were someplace where you had an 2-hour ride to a hospital, and that does exist in New York, right? You could be up in the Adirondacks and, be doing a 2-hour, evacuation out of the woods. So if that's the situation and you feel the bleeding is controlled, you can start backing the pressure off a little bit and see if the, bleeding has stopped. Now, if I was carrying somebody out of the woods where there's a lot of jostling and stuff like that, I'd be very careful because it may not look like it's bleeding and then you're bouncing them around and it starts bleeding again. But well, actually, I didn't plug in the microphone. People don't hear me. You guys hear me?
Okay. If if you're in a situation where you had to do a lot of movement and stuff, then I would really, if you do loosen a tourniquet, I would really watch it. I had the accident on the 17. I don't remember if it was this past summer or the summer before, where the two guys were riding on the motorcycle, the lawnmower, and they got hit by a car. The two drunk guys on a garden lawnmower, a Toro lawnmower. So, my guy died because the police, when they showed up, they were there. There was a cop there first. He put 2 tourniquets on the guy's lower extremities because his legs were basically destroyed. And I put a tourniquet on his right arm. And when we were going to the hospital, there was still bleeding coming from somewhere, and we couldn't figure out what was going on because there was a lot of blood on the floor. And what it turned out to be was that the guy loosened his tourniquets because they hurt so much. So he reached down and actually pulled on them until he loosened them. And we saw the tourniquets were on, and it didn't seem like there was any bleeding, but he actually loosened them. So he probably died from, a whole bunch of blood loss prior to us getting the tourniquets back on. Because once we retightened the tourniquets, he kept on trying to loosen them because he said that they just hurt so bad. And tourniquets do hurt, right? I mean, if you wrap something around your arm and crank down on it, it's going to be painful. So, but the protocol does say that you can loosen to it. Again, I don't think in Rockland County there's going to be much of a time where we actually, loosen tourniquets, but technically you could. Okay, so again, a tension pneumothorax can occur when you had that open pneumothorax, okay, and the blood caused the occlusive dressing to stick, okay, or you forgot to seal it only on 3 sides or something like that. If that's the case, then break the occlusive dressing loose and see if you can vent some of the pressure out. You'll actually hear, if it was sealing the chest and there's pressure building up, you would actually hear a whoosh of air. And remember, like they showed you in that video, if somebody has a lot of meat on them, okay, depending on how you shift them, you can actually take that open pneumothorax, which is venting the pressure to the atmosphere so they're not getting a pneumothorax, a tension pneumothorax. You could turn it into a tension by shifting tissue and having it seal. Okay. So how else can you get a pneumothorax, or even a tension, or even a simple pneumothorax? You can get it from a rib fracture that punctures on the way in. Not very common, okay? So it could puncture the lung, or it could puncture one of the main stem bronchi. It can result, we said, from a spontaneous pneumothorax, which would be a non-traumatic pneumothorax caused by weakened lung tissue. Typically, we said in COPDers or tall, thin people. So what happens when somebody has a tension pneumothorax? The first thing is they get stabbing chest pain, right? They get intense stabbing chest pain, and it's very difficult for them to breathe, because when they inhale, just like anytime you have pain in your chest, it hurts more when you inhale. So they're going to have trouble breathing, stabbing chest pain. Now, all the other things I'm going to show you pictures of, and I'll explain why they're happening as we go along. So let's start from the bottom. They're going to have absent or decreased lung sounds over the affected side. So what's that mean? If your lung is collapsed, okay, you're not going to hear the sound of the air going in and out of the lung. So now, if they have 100% pneumo, it's silent. If they have a 50% pneumo, it's diminished. Now, the issue is that if somebody has a small chest cavity, especially a kid or a female has a small thoracic cavity, you can get what's called referred breath sounds, which is very confusing. So picture again, I have 100% pneumothorax on this side, right? So this side is basically an air-filled cavity, like a drum, because the lung is collapsed. So I mean, it's there, it's about the size of my fist, but it's kind of, right up against my mediastinum, the middle of my chest. This side is working fine. So now when I breathe, the sound from this one carries across, because sound travels very well in an air-filled cavity, like a drum, right? I mean, you have a drum that you beat on, right? The sound travels through it. So sometimes it's hard to 100% know that somebody has a pneumothorax, because yeah, you hear them on the side the lung is working on, but you think you hear it when you're over here, because you're hearing the referred breath sounds over. So that's the issue we face in the field. It's sometimes very hard to say that the lung sound is not there because of that. Okay, now the rest of the stuff we'll go through. So this is showing you somebody, okay, who's got the pneumothorax on this side, and you can see the lung here basically being collapsed. The other thing you could see is that here's the pericardial sac of the heart, and it's almost all the way to the left side, right? So that's what's called, all this pressure is kind of, moving over. And the other thing, they have a right-sided pneumo, is the diaphragm, right, should be going like this, okay? But again, because of all the pressure, the diaphragm is actually collapsed back down. And since it's on the right side, it's actually displacing the liver downward. Okay, so that's a pretty big one. On the CAT scan, so again, here's what's left of the lung a little bit, right in here. And you can see, here's your heart. It's displacing the heart almost all the way over, okay, to the other side from all the pressure. So air pressure, right, is, fills a tire up, so it's very powerful. The other thing that this patient's getting with the pressure is they're getting air leaking up into their tissue, right? Here's their rib cage. The air is leaking up into here, and this would be called subcutaneous emphysema, which is, again, a horrible word. It's not emphysema like the disease, but basically there's air that worked its way under the tissue, and probably on the outside of this guy's chest, we'd start seeing some bubbling of their chest, of their skin from the air pressure that's underneath there. Now, jugular vein distension. So this is fake jugular vein distension. This is some guy that was, bearing down like he's going to the toilet. And when you bear down, you increase the pressure in your chest. So your jugular veins are the big veins that are emptying downward, right? Your carotids are bringing blood upward. Your jugular veins are bringing blood downward. And you have these are your external jugulars, and you have your internal jugulars right underneath them. So you really only see the external jugulars. But what happens now, the reason you see jugular vein distension and tension in the thorax is we said that the chest is pressurized, right, from the tension, from the pressure of the lung. So the same thing happens. It's difficult for the venous blood to empty down into the chest. So you'll see that. And it's never normal to see jugular vein distension in somebody who's sitting up, right? And you may see it if somebody's been lying down for a long period of time just because blood pools, but it would not be normal to see it on somebody sitting upright, or even somebody sitting semi-Fowlers at a 45-degree angle. Now, tracheal deviation. So here's your trachea. See this tube coming down? Okay. And these are your main stem bronchi. The reason they're both on the same side is, again, because the person has a tension pneumothorax. So what basically happened over here is that this trachea should be coming right down in front of the spinal cord. But because of the pressure on this side, it's deviating over. But if you look up in the neck, it's midline. So the only place we could see the trachea, right, is to look midline. Like if you reach in right over here in your jugular notch, you can feel your trachea moving. So if we were to feel in there, this guy's trachea probably would be somewhat, midline. Maybe this is such a big one, it's a little deviated, but it's really considered an X-ray finding because you really only see it on an X-ray. And this is, again, just showing it a massive pressure that's building up and causing everything to kind of shift over. Now, subcutaneous emphysema, okay, is basically when air traps underneath the skin. So it's gotten out of the lung or it's gotten out of one of the air passageways, one of the bronchioles, and trapped underneath the skin. And they get a very distinctive, I don't know if you could see, they get these bubbles over here. So this guy probably had a seatbelt injury, and he broke a rib probably from being thrown. This might have been in the days before the seatbelts, had the tensioners where it kind of let out a little bit before it to let some of the energy out, or again, no airbags maybe or something like that. But he's starting to get subcutaneous emphysema, okay, developing even along the welt here, but in here, okay. Now I've only seen subcutaneous emphysema once in my life, and it was actually not trauma. It was a patient having oral surgery, and in the midst of having a tooth extracted, the dentist noticed that the side of his face and the side of his neck was rapidly expanding. And they speculate that they sometimes they use compressed air to clean out the wound and stuff like that. That somehow that when they were doing it, plus the incision, plus everything else, that it worked its way in, and the guy's right side of his body looked like Quasimodo, or the right side of his face and neck looked like Quasimodo. So they stopped the surgery and sent him to the hospital. Most of the times, the subcutaneous emphysema in itself is not dangerous. In this case, or the picture we're looking over here, this is such massive that's probably interfering with the chest wall moving. But most of the times it's not that dangerous, and it just gets reabsorbed into the body. It's more the wound that caused them to get the subcutaneous emphysema, the punctured lung or the punctured bronchial or something like that. So again, this is just showing you somebody with massive subcutaneous emphysema. When they push it, it tends to slide over, the air and stuff like that. So they get all puffy. Now, one of the most reliable things you could do to diagnose a pneumothorax is to see whether the chest is symmetrical. So symmetrical means that both sides are the same and that they rise and fall equally. So when somebody has an asymmetrical chest, it's very indicative of a pneumothorax, or at least some kind of chest wall injury. Okay. Just an interesting note here, Bob. This is the old Philadelphia collars that we used to use 20 years ago, two-piece collar. So this picture is fairly dated. Nowadays, everything's the stiff neck, or the fake stiff necks. But when we look at this guy's chest, we can clearly see that his right side is lower than his left side, right? Now, it's hard to diagnose what's going on because we don't know, was this guy breathing in or breathing out when this picture was taken? But think about it for a second. If I tell you this guy was exhaling, okay, when this picture was taken. So he was exhaling, both sides of his chest should go down, right? That's what should happen. But since his left side of his chest is staying up and the right side is going down, we have to assume that the injury happened on his left side. And probably it's what? It's probably a tension pneumothorax, because that means there's pressure not letting this side come down. So if you see an asymmetrical chest on exhalation, on when somebody's exhaling, and the side that does not go down probably is the side that has a tension pneumothorax. So you would expect to hear absent or diminished breath sounds on this side. You'd expect probably that there's a wound on this side unless they had a spontaneous pneumothorax. Now, if I shift it the other way and says picture was taken when the patient was inhaling, then we'd say both sides should go up, right? So that means now the problem's on the right side. So the right side is not going up. So what happened here, it's not a tension pneumothorax, there's no pressure, it's a simple. So a simple pneumothorax means there's a hole in the lung can't expand. So that this lung is collapsed, and when he breathes in, it doesn't work. So again, asymmetry or asymmetrical chest on inhalation, typically would say the injury is on the side that doesn't go up. So this would be the right side. And you'd expect, again, to have absent and diminished breath sounds on this side. And also, if there was trauma, to have some type of injury you know, on that side. And remember, when I say that side, it's not here necessarily. It could be lateral, right, from the armpit all the way down to the pelvis, or it could be the back, right? So it could be, you got to look at their entire back, because they could have a stab wound. I think I have some pictures coming up. They could have a stab wound on their back, and if you just leave them supine, you'll never notice it. Okay, again, if you had a patient who had a sucking chest wound and they were doing good, and then you sealed it and they got worse, then you need to break the seal to vent the pressure out, okay? The paramedics, if it's a tension pneumothorax and they're 100% certain, would do what they call a needle decompression, which is that they would find a specific landmark, the second intercostal space mid-clavicular. So they find a clavicle, the collarbone, go in the middle of it, that's the mid-clavicular, into the second intercostal space, which is the space between the second and third rib, and stick a needle in there. The important thing to remember is that running under each rib, okay, so you got 12 ribs running under each rib, okay, so you got 12 on each side, 24, is what they call a neurovascular bundle. So under each rib, you have an intercostal nerve, intercostal artery, and intercostal vein. So when you stick that needle into the second intercostal space, you actually want to be right above the third rib, never going under the second rib, because if you stick the needle under the second rib, you're going to lacerate the intercostal artery and vein, and on top of everything else, cause a bloody mess. Now, this is probably the thing that most paramedics fear having to do, because you're not doing a chest x-ray to be 100% certain that there's a tension pneumothorax. So if you made a mistake, okay, and there was no pneumothorax, and you stuck a needle in this guy's skin and drove it into their chest, you now made a hole in their lung and you now caused a pneumothorax. So that's why it's kind of a tough decision to make, you know, in the field without a, you know, a chest x-ray or a CAT scan or something like that to be able to 100% know. So most trauma patients have a combination of what they call a pneumohemothorax, air and blood, because if it's trauma, there's probably bleeding. And the deal with hemothorax, right, is that you can lose pretty much half your blood into your chest cavity. So you can bleed to death in seconds, if not minutes, in your chest cavity, and there's no way we can control that bleeding except getting them into surgery. So the quicker we get that patient into surgery, the better it is. Remember, you can't control bleeding. IVs are not what they need. They need blood, and we don't give blood in the field. So the quicker you get them into the OR, and the quicker somebody cracks their chest and finds out what's bleeding and clamps it, the better their chances of survival are. So if you have somebody shot, it's probably not just a pneumothorax, it's probably a hemopneumothorax. Now, one of the more common, you know, injuries that we have would be rib fractures. Okay, it can happen from sports, it can happen from a fight, it can happen just from falling down in older patients and stuff like that. A simple rib fracture, the danger would be the pain stops them from taking a deep breath, so they don't ventilate well. They have limited mobility when they have a rib fracture, so they're more prone to having pneumonias later and stuff. So most of the care of a simple rib fracture would be pain management so that they can get back to normal activity. Now, the amount of pressure that somebody has to exert on a rib to fracture it is usually fairly significant. So the pressure doesn't, or the pressure or the force doesn't just stop on the rib. Remember, it hits the rib, but it's transmitted down onto the lung. And a patient can get an injury called a pulmonary contusion. So pulmonary contusion, you've all had contusions. Contusion is that you got punched in the arm and the blood vessels under the skin broke and you got a black and blue. A pulmonary contusion is that you got punched on the rib cage, okay, or you fell or something like that, and the energy traveled from the rib, and it may have broken the rib, okay, but it also traveled and hit the lung. And remember, your lung is very vascular, and it lacerated the blood vessels in the lung, and they get a big contusion. That whole area that's contused doesn't have gas exchange. So most blunt chest trauma has a pulmonary contusion. A pulmonary contusion can only be picked up on, you know, maybe on a CAT scan, but usually on a MRI or PET scan. So it's a little hard to pick it up. But what'll happen is that patient's pulse oxes will be chronically low no matter what you do for them. Okay, and that's a typical thing. Now, you know, again, we said you had 12 ribs. So when we were talking about decompressing the chest because somebody had an injury, here's your clavicle, right? You have a clavicle on each side, your collarbone. So you go mid-clavicular, so you'd find the middle of it. Second intercostal space. So here's your first intercostal space, rib 1, rib 2, rib 2, rib 3. So the needle would kind of go like right over here, say. And we said we want to avoid being under the rib because of the intercostal bundle, nerve, artery, and vein. So we'd want to be feeling this rib and sticking it right over. Okay. You know, down at the bottom, your bottom two most ribs, okay, don't connect to the front, so they're called floating ribs. So they're typically not fractured because, you know, they have the ability to move a little bit. But the more common ones that would be fractured are ribs in here, 4 through 9, okay, are the more common ones that are fractured. Ribs 1, 2, and 3 are short, thick ribs, so they're not usually fractured, but if they are fractured, it means there was a significant amount of energy expended upon them, so they usually do have that pulmonary contusion underneath it. Clavicles are very easily fractured, okay? So a clavicular fracture is a fairly common one, and it's pretty rare to fracture a sternum, okay? But it can happen, but it's pretty rare to fracture a sternum. You know, I know that, you know, with CPR, they always used to say, you watch your hand placement, or CPR can cause rib fractures, or you've done CPR on an elderly patient, you think you're breaking ribs. If your hand is on their sternum, okay, you're not breaking ribs. But what happens is a lot of ribs are attached to the sternum by cartilage, so that when you're pressing on, especially an older person's sternum, you're going to hear the sound of the cartilage cracking, just like if you're breaking your knuckles. So it doesn't necessarily mean that you cause rib fractures. It's just an old wives' tale. Okay, so one of the more serious rib fractures is what they call a flail chest. So a flail chest is where you have 2 or more ribs. I know this says 3 or more ribs, but most of the times it says 2 or more ribs fractured in 2 or more places. So basically what they'd be saying is that this rib is fractured here and here, and this rib is fractured here and here, and it could be so on and so on all the way down. But that this section in between the 2 fractures, okay, is now free floating. Now it doesn't really free float, because what happens is the muscles spasm and lock it in place. And they used to use this term paradoxical movement. So it's not really what happens. So they used to say that when you breathe in, right, your chest wall goes out, but that those ribs travel in the opposite direction. But really what happens is, because that the intercostal muscles spasm, when the rib cage goes out, they just lock those pieces in place. So it looks like they're going in, but they're just actually staying in place while the rest of the rib cage is going outward. So, and sometimes it's hard to see it, especially if somebody has a big chest, or a woman, say, has breast tissue and stuff like that. So most of the times you would feel it by palpation. You'd feel that kind of some ribs are not moving. Okay, so, obviously the more ribs that are fractured, the more energy that was expended, the more the risk of a pulmonary contusion, okay, and the more trouble breathing they're going to have. And again, a rib fracture, whether it be flail or not, the biggest killer is hypoxia. So if you look over here, let me take my glasses off. Okay, so this person has, okay, ribs 3, ribs 4, ribs 5, and ribs 6, right? Has a fracture, a fracture, a fracture, a fracture, right? So on and so on, all the way up. So he's got a 4-rib flail segment. So that's a significant one. Plus it's involving some of the pretty thick ribs, right? Rib 3 and stuff like that. So it's probably caused an underlying, okay, hemothorax. Now the repair, okay, and I'm hoping nowadays they have a better one, but the repair back in that day was they actually took what we used to call finger splints, and they put it over the ribs to stabilize it in place. Okay, a lot of times nowadays, most of the times nowadays, for an isolated rib fracture, it's just pain management. They don't actually, do any type of surgery or anything like that. But I guess a flail segment, because there's so many ribs involved, and because of the lack of movement of the chest wall and the hypoxia, they have to stabilize it. So I found this picture on the internet. So this is from the 40s, what they did for somebody who had a flail segment. And they took a metal rod, metal skewer, and they drove it through the pectoral muscle on either side of the fracture, right? So these ribs were fractured in here. And I guess the corks were a safety device. So that's what they did years ago to stabilize a flail segment. So some of us might be smiling, saying like, oh my God, how stupid they were. But trust me, things we're doing nowadays, if you go 50 years in the future, people will be, laughing at what we did. I can think back to, not that long ago, where we used to use the mesh trousers on trauma patients. For 3 years, we were using them on trauma patients, and then even on cardiac arrest, and they were supposedly the greatest thing since sliced bread, and we were saving all these people. And then after 3 years, they found out we were just killing them quicker. And, now they're relegated, if anybody even has them, to basically a big air splint for lower extremity fractures. If you even still have them, most people don't even buy them. The state doesn't even require them, and they don't even look for them. Okay. So The biggest risk of any blunt trauma to the chest, okay, that can result in a rib fracture or not, would be that pulmonary contusion, which is the big bruise that develops on the lungs, okay? And just like any clot, it takes a, contusion takes a while to develop, but that whole area is not available for gas exchange. So again, the danger would be the hypoxia that develops. So the low O2 levels, the high CO2 levels, okay? And probably the decrease in tidal volume, the depth of the breath because of the pain, stuff like that. Okay, so that's the pneumothorax that we talked about, the pulmonary contusion. So now we're going to get on to a couple other ones, pretty rare injuries, but, probably never see them in your careers, especially, in Little Rockland County and stuff like that, but it could happen. So if you have any questions, unmute yourself, but traumatic asphyxia. So another terrible word, right? So the traumatic part is probably good. The asphyxia means that somebody was choked or strangled. So this is not what happens here. In traumatic asphyxia, what basically happens is that there's a sudden pressure exerted on their chest, whether they fell or whether something fell and pinned them onto their chest, and it compressed their heart between their sternum and their spine. So it squeezed their heart and blood regurgitated backwards. So blood came out of the right atrium and shot back up into the jugular veins and back up into the face. And they get bulging eyeballs. They get a purplish discolorization, typically from their clavicles all the way up through their face, almost like they're cyanotic and stuff like that. And again, if they didn't die from the compression injury, in other words, if this was a 2-second compression injury, all that blood will get reabsorbed and everything should work fine. But, you could imagine the amount of pressure that has to be exerted on somebody. I've never seen this, but somebody who had, a stack of lumber fall on their chest or a metal plate fall on their chest or something like that, it could happen too. I've seen people that were in trenches, doing construction, and the soil collapsed onto them. They don't typically get traumatic asphyxia. They do get cyanotic. They get cyanotic because they can't move their chest to breathe, and that's typically they die of suffocation. So they don't get the neck veins being distended. They don't get the eyeballs, being engorged with blood or anything like that. Again, there's nothing you could do for these people. I mean, it's oxygen and transport. And again, this would be a situation that has to go to a trauma center, ideally a level 1 trauma center. A blunt myocardial injury. So you could have somebody hit with a line drive to the chest. You could have somebody kicked to the chest. You could have somebody hit with a baseball bat in the chest, right? If it's hit right over the heart, okay, you could have a bruising of the heart, a myocardial contusion, just like over the lung, and they'd be more at risk for arrhythmias, for abnormal heartbeats. So we would always put them on a monitor on a BLS level. You would always check for a pulse. If the pulse is irregular, you would suspect a myocardial contusion. If somebody was, struck in the chest with significant force and they had an irregular heartbeat, I would probably put the AD pads on them just to be on the safe side. You don't even need to turn on the AD as long as they're talking to you, but I would put the AD on just to be on the safe side. So if they code, right, you have the AD in place. Now, there's a specific injury called comiocortis. So what happens is, this is the kid who gets hit with the line drive, high speed baseball, hockey puck, lacrosse ball, high speed impact, dead center in their chest over their heart, and at the right point of their EKG complex, and it throws them into VFib. Okay, so if you get the story where somebody was struck in the center of their chest, I guess technically if somebody was like a martial arts kind of guy, and could strike really quickly and hit somebody in the chest, it could cause it, but it's a sudden impact in the center of the chest, okay, and it causes the patient to go into VFib. So obviously, if that's the case, if that's the story, the AD goes on the patient. If the AD says shock indicated, they're in VFib. And if you're there quick, it would be probably a save, because you'll reconvert the injury, reconvert the VFib back into a normal rhythm by defibrillating them and put them back in the heart. But a myocardial contusion could be secondary to that, line drive to the chest. But if they're conscious after the strike to the chest and they're just complaining that their chest hurts, they don't have this comiocortis because they would have been in VFib already. Pericardial tamponade was what we were talking about, the Kawasaki. We said they get an aneurysm, and sometimes if the aneurysm bursts, that their pericardial sac could fill with fluid and they get a pericardial tamponade where the heart sac fills up with blood. So again, because we're talking trauma, this is usually more from a traumatic situation where they lacerated a coronary artery and it leaks into the pericardial sac. I've never seen it. It's usually fatal. The treatment would be to rapidly transport them to the hospital, and they would have to, with ultrasound guidance, take a syringe with a long needle and evacuate out the fluid from the pericardial sac. Usually they do it under ultrasound guidance, so they know that they're not sticking the needle into the actual chambers of the heart, but just to the space between the pericardial sac and the heart itself where the fluid is. Usually it would be a cardiologist. I would assume they'd have to get in. I mean, unless there happens to be a very gutsy emergency room doctor to do it and stuff like that. But again, I've never seen it. It's pretty rare. You can get people who have a medical, I guess, version. I don't know if that's the right word, but a medical similar thing where they get what's called a pericardial effusion, which means they get an infection in the lining of their pericardial sac. And anytime you have an infection, there's fluids that build up because of the infection, and they can get similar symptoms, not as severe, with it. And a lot of times people who have pericardial effusions actually present to us like they're having a heart attack because they're having chest pain, they have EKG changes and stuff like that. It's usually diagnosed again with ultrasound where they could see the fluid in the sac. A lot of times that's initially treated with antibiotics if they're not symptomatic, but if they're really dropping their pressure and stuff like that, they'd have to have what's called a pericardiocentesis, where they pull the fluid out of the sac. So again, this is showing you obviously on autopsy somebody who had a massive pericardial effusion, and they were just trying to get the fluid out, but that's basically what happens in here. So they're showing you that this whole section is filled up with fluid, so it's compressing the heart and not letting it fully expand. So this is an interesting guy. This guy was shot in the chest with a nail from a nail gun. So let's orient ourselves. So this is his head up here, okay? This is his armpit, okay? His belly button's down here. So here's his nipple, okay? And he was standing on one side of a sheetrock wall, and the other guy on the other side with the nail gun thought he had the nail gun pressed up against a stud, right? To make a nail come out of a nail gun, there's a safety that has to be pressed up against something, so you can't just shoot like nails in the air. But when he pressed it up against the sheetrock, I guess the sheetrock was strong enough to allow the safety to depress. When he pulled the trigger, there was no wood behind it, so it shot right through the sheetrock and went into this guy's chest. Okay, so judging from where it is, and they told us it was like a 3.5 inch nail, and it was sticking out about a 1/2 inch from his chest. Was by the lung, it was by the heart, it was everything. Guy was totally awake, conscious, no complaints or anything like that. Some minimal bleeding, and we took him to the hospital. They CAT scanned him. It wasn't hitting anything important, and they just pulled it right out. So even though it looked fairly significant, it didn't turn out to be anything. So remember I told you before how important it is to log roll a patient and look at their back. So this is still your thorax. Your lung is still right behind here. And this was a guy that was stabbed twice, okay, here and here, with a knife in through his chest. Nobody knew he was stabbed until they log rolled him. This is back in the days of longboards, till they log rolled him to put him on the longboard, right? So luckily, neither one of them were deep where they actually went into his lung. I don't know how they didn't, because the knife was pretty big, but that's why it's very, very important to log roll somebody and check their back. So really, he should have had occlusive dressings on these 2 wounds. This was a guy. So here's his head. Here's the collar. This is his. This would be his left scapula, his left shoulder blade area, and this is his right side down here. This was a guy that was attacked by a dog. The dog took a big chunk out of his shoulder, knocked him to the ground, and then bit him on the shoulder. And there was a big question if the lung was actually involved, in this injury. It didn't turn out to be, but it was a big question on whether or not the guy actually had a lung wall injury. Okay, and then this is the last one. So that's my ear. That's me. This is a 2x4 embedded in a patient who was conscious, alert, and oriented. He was drunk, driving a car on 17 in Tuxedo, and he hit a picket fence. So this piece of wood was, I think, 6 or 8 feet long. It was what the pickets were nailed into. So there's 2 pieces going horizontal, and then there's the vertical pieces that are nailed onto this. So when he hit it, all the vertical pieces flew off. He broke this, and it went in. So this is his right side. It came in through the passenger window, okay, and came across and impaled him. And you could see it a little bit over here actually trying to come out this side. It didn't come out, but it was bulging onto this side. The guy was upside down with, 8 feet of wood sticking out the window, this stuck in him, conscious, alert, and oriented, saying, I'm stuck on something I can't get out. And, we took a Sawzall, we shortened it. He was conscious and alert and oriented all the way to Good Sam. Good Sam took one look at him and said, oh my God, get him out of here. And this is many years ago when they were still a trauma center. And we took him then from Good Sam to Westchester. He was still conscious, alert, and oriented to the OR when they did the CAT scans on him before they took him to the OR. They saw that he pretty much destroyed everything in his belly, part of his liver, everything in his intestine. He had broken his spine, which is why he had no pain. And they basically opened him up and he immediately died. And that was it for him. But he was alive for probably almost 2 hours. So that was even though it wasn't really a thoracic injury, it was pretty impressive injury. Okay, and then the last thing, and then we'll open it up for questions, is for abdominal, because there's a test question on that. So, an evisceration. So an abdominal evisceration means that somebody was cut across their abdominal wall, and that they usually say an organ, but it's most of the times it's, it isn't an organ, but your intestine that comes out. It's not usually your spleen or your liver or anything like that. It's usually a bowel loop or loops, like in this patient's case, loops of bowel that came out. So I've only seen it once or twice. One time was a suicide attempt. One time was an ATV accident in the woods. They hit a fence, barbed wire fence that was kind of camouflaged. They didn't see. So, it's probably more gruesome than it's anything else. Most of the times they do fine. I shouldn't say they do fine. Most of the times the injury is not what actually kills them. It would be perforations. It would be infection. There's definitely a quality of life issue if there's any kind of injury to the intestine and they get adhesions and stuff like that. But, what do we do? So all we're going to do is cover the organs in a moist sterile dressing, and then over the moist sterile dressing, try to put something that is airtight. Now, we're not putting it airtight like we did with the pneumothorax and occlusive dressing. We're trying to put something over it. And, in this case, it looks like they just put an occlusive dressing with some tape over it. I'm sorry, a trauma pad with some tape over it. That's fine. All we're trying to do really in this situation is to stop heat loss. Because if this is a cold night and his abdominal cavity is open, he's going to get hypothermia very, very, very quickly. So that's all we're really trying to do. Again, I wouldn't stay on the scene to try to do it, rapid transport. And usually touching the intestine, a moist sterile dressing. But again, if you're worried about heat loss, I wouldn't soak the dressing to the point, where water's flowing off of it. Just a little bit of moist so it doesn't adhere to it. And again, it's not that big of a deal. They're going to be irrigating out all this intestine and stuff like that in the operating room. But usually we'll say a moist sterile dressing, touching the intestine, and then something airtight over it. And again, it's not airtight because you're worried about sucking air in and out. It's airtight because you're just worried about heat loss. So you're more or less a temperature barrier type of thing. Okay, so that's basically everything I had. Everybody's unmuted. So does anybody have any questions on anything or anything, it doesn't have to be about the lecture tonight, but anything we want to talk about? Nothing? Everybody's good? Any questions on?
Right, yeah, one question. What's the best position to put somebody with a sucking chest wound in?
Oh, actually, well, let's backtrack. What's the best position to put somebody with an abdominal evisceration in? So they're probably going to be on their back, but their legs should be what? Flat or flexed?
Flexed.
Flexed, right. But just because you won't be putting as much pressure on it, right? So somebody who has an abdominal evisceration should be flat on their back, supine, but if you can, pad some padding under their legs so that, there's not as much pressure. So they used to say years ago for the tension pneumothorax to position them on the side of the pneumothorax, which would mean you put them, let's say if they have a left lateral recumbent on it, but they kind of found that makes it much more difficult for them to breathe. So I've not had somebody with a tension pneumothorax who's been awake, conscious to the point where it really mattered. So if you have to work on them, they're going to have to be supine, if you have to do things and ventilate them and stuff like that. So I would say the vast majority of times they're probably just going to be supine. It's not going to be, I know one time I saw them bring a kid in with a spontaneous pneumo, and he actually said he felt more comfortable laying on the side that had the pneumo. but that was a conscious patient with a medical pneumothorax, not a trauma pneumothorax. And he had it, you know, he had a history of it. He knew it, what he had and everything. So the diagnosis was pretty simple. But I would think real life wise, probably going to be flat on their back. They used to say, like, if you put them on the side of the organ, it would let, you know, in other words, it would let things kind of press back down, you know, but you can't overcome that pressure just by positioning someone. Okay, does anybody have any other questions on anything? Okay, so just remember again, hemostatic gauze, right, should come in contact with the bleeding vessel. Hold it in place for up to 2 minutes. Pack more gauze on top of it, and, you know, direct pressure and everything like that. If the hemostatic gauze fails, then you go right to a tourniquet, right? You're not going to try to add to it or anything like that. Just go right to a tourniquet if the bleeding is severe and you think the patient's going to. I'm just going to, hold on. I'm going to mute. I think I got the person. Okay. The other thing they would ask is signs and symptoms of somebody going into shock, right? So typically the skin gets cool, pale, and moist. They get tachycardic. They get tachypnic, which is rapid breathing. And then they're going to, what's the difference between early shock and late shock? That in early shock, you have these compensatory mechanisms, the vasoconstriction, the heart squeezes harder. There's, you know, bleeding control trying to be done in the body by platelets and fibrin and stuff like that. Tries to keep the pressure up, the blood pressure up. So a late sign of shock would be a falling or a low blood pressure, right? But early on, the skin's going to get pale and moist. The patient's going to get anxious, nervous, restless, and stuff like that. Just trying to think what other questions there might be. I think that's basically it. I mean, you have as long as you want to take the test. So if you need to look stuff up, that's even better, right? That's really the purpose of doing it, is to do some research and stuff. You can take the test up to 3 times. You need to get a 70 or better. So I think it's 20 questions on it. And it's the same questions each time. So nobody ever fails it or anything like that. And then once you're finished with the, once you're finished and you get a 70 or better, if you don't get a 70 on the first one, you just take it again. Once you get a 70 or better, it'll email you a copy of your certificate. You hold on to it for your records. I will get a copy on my own. And I think that's really everything, unless anybody has any questions on anything.
Yeah, Frank, I have a question, but it's not related to this.
Mm-hmm.
Is anyone at the medic building?
I would assume so.
Oh, okay, because I've been making masks. And in this batch, they're going over to RPS and mobile care.
Are you talking headquarters or are you talking Medic 21?
I'm talking headquarters.
Oh yeah, there's a dispatcher here 24/7, but I mean, it'd be better to come during the daytime.
Oh, I would go in the daytime.
Yes.
I'm just I ran into Joel a couple of weeks ago, and he told me that it would be 2 dozen for our Rockland Mobile Care and 2 dozen for the RPS.
Okay, thank you.
You're welcome. You're welcome.
Anybody have anything else? Okay, so I will send out the link to the exam. If for some reason you don't get it, just contact someone else. I think I have everybody's, you know, obviously if you're on tonight, you got an email from me. So, but if you don't get it, somebody else can forward it to you. And, you know, everybody have a good night, stay safe, and I guess we'll see each other next month.
Thank you very, very much, Frank.
Okay. Everybody have a good night. And I'll post a video up on YouTube. I'll send the link out probably tomorrow morning if anybody needs to relook at it or anything like that. Okay?
Great. Yeah,
take care.
Thank you.
Bye-bye.